Sleep-wake disorders are some of the most misdiagnosed topics on exams. Never miss these questions again. First, let's talk about the super high-yield medical condition that can cause insomnia, sleep apneas. There's two different types, obstructive versus central. You need to know the difference between these two. Obstructive is going to have repetitive upper airway collapse during sleep. These patients are going to present with excessive daytime sleepiness, loud snoring, frequent awakenings, gasping, choking episodes because they can't breathe, and then they're going to have morning headaches because of CO2 retention. Now, risk factors are going to include obesity, increased neck circumference, and male gender, although plenty of females have this as well. And the treatment is going to be positive airway pressure. There's CPAP, BiPAP, and you're going to want the patient to work on losing weight and exercising because obesity can contribute to the obstructive sleep apnea. You also want to advise them to avoid alcohol and sedatives before bed. Now, for central sleep apnea, there's cessation of breathing without respiratory effort. It's often idiopathic, or it could be secondary to a medical condition. Cheyne-Stokes breathing, a crescendo-decrescendo pattern, is something that you need to know how to recognize for central sleep apnea. It is associated with heart failure, stroke, renal failure, opioid use, so look for those things on the exam stem. For management, if there is an underlying medical condition, you want to treat that in order to help the central sleep apnea. You can also use CPAP, BiPAP, ASV, and subliminal oxygen. Acetazolamide can also be used because it is a respiratory stimulant. So how I remember the difference between obstructive and central sleep apnea is obstructive is more of a blockage, whereas central is the brain forgot to breathe. So it's important that we rule out sleep apnea when we're diagnosing insomnia disorders because we always want to rule out medical conditions. But what if someone has a primary insomnia disorder? Well, the diagnostic criteria for insomnia disorder is difficulty initiating or maintaining sleep or early morning awakenings for at least 3 nights a week for at least 3 months. That's the rule of threes. So just think 3 nights for 3 months. First-line treatment is not medication. It's actually CBT-I, cognitive behavioral therapy for insomnia. That is the gold standard for a chronic insomnia. Pharmacotherapy, non-benzodiazepines for short-term use can also be used. A lot of psychiatrists use medications such as trazodone or hydroxyzine for off-label use, but they're not that great. CBT-I is first line and will have the least side effects. But what if you have a patient that comes in and they're super tired and sleepy, but they've had plenty of sleep. They're not having trouble falling asleep or staying asleep, but just sleepy all the time. This is where hypersomnolence disorder comes in. It is excessive sleepiness and daytime napping. The criteria for hypersomnolence disorder is they must have excessive sleepiness despite having at least 7 hours of sleep per night, and this must occur at least 3 times a week for at least 3 months, just like insomnia, 3 times per week for 3 months. Key features are non-restorative sleep, waking up unrefreshed, difficulty awakening, and automatic behaviors with little recall about these behaviors. Treatment is usually lifelong therapy with modafinil, which is a wakefulness-promoting agent, or stimulant such as methylphenidate. Next, we're going to talk about circadian rhythm disorders, and this is internal clock misalignment. So circadian rhythm disorders are recurrent sleep disruption due to misalignment between the internal circadian rhythm from the suprachiasmatic nucleus and the required schedule. Remember the suprachiasmatic nucleus because it will show up on PRITE exams as being associated with circadian rhythm. Common subtypes are delayed sleep phase, which is the night owl, advanced sleep phase, which is the early bird, shift work, and jet lag. Treatment is timed bright light phototherapy and melatonin. For management, the patient should maintain a fixed sleep-wake schedule and minimize evening blue light, which is really hard for everyone because everyone looks at their phones, and take strategic naps for shift work. All of these are behavioral modifications that can help with circadian rhythm disorders. Next, we will talk about the super high-yield topic of narcolepsy. Narcolepsy will show up on your exam, so you need to know it well. Narcolepsy is a disorder of REM sleep regulation. In order to meet criteria for narcolepsy, a patient must have recurrent episodes of irrepressible need to sleep, lapsing into sleep, or napping occurring at least 3 times per week for at least 3 months, like the other sleep disorders. Now, they must meet this criteria plus one of the other 3 criteria, including cataplexy, which is a sudden loss of muscle tone triggered by a strong emotion, and they must have at least several of these episodes occurring several times per month. Or the patient could have hypocretin deficiency, which is low levels of hypocretin-1, orexin, in the cerebral spinal fluid. This is high yield. It may show up on your exam. Or the patient could have REM sleep abnormalities. So when this patient goes and gets their sleep study, it may show a short REM sleep latency of equal to or less than 15 minutes, or a main sleep latency of equal to or less than 8 minutes, with at least 2 sleep onset REM periods. Other symptoms that these patients may experience but are not part of this DSM criteria are the sleep attacks, which are irresistible, refreshing naps throughout the day, hypnagogic hallucinations, which are vivid hallucinations when falling asleep. Hypnopompic is waking up, so P for popping up and G for going to sleep. And they might also have sleep paralysis, which is the inability to move upon awakening or falling asleep. That can be pretty scary for patients. So you need to know the physiology. Loss of hypothalamic hypocretin, orexin, as we had talked earlier. That is the physiology of narcolepsy. You will be tested on that. For pharmacology, for daytime sleepiness, modafinil can be used. It is a non-amphetamine stimulant, or methylphenidate can be used. For cataplexy, sodium oxybate or REM suppressants such as venlafaxine, fluoxetine can be used as well. Management also includes scheduled daytime naps. So remember your pharmacotherapy because that is highly tested as well. Next, we'll discuss another high-yield topic, which is NREM sleep arousal disorders. These are also highly tested. These include sleepwalking and sleep terrors. So these occur during the slow wave sleep, N3. Remember, N3 for NREM sleep. Very important. You will be tested on this. Typically, within the first third of the night do these occur. And this is important. There's amnesia for the episode. They're difficult to arouse. They're not going to remember this. Unlike with nightmares, they're not going to remember doing these things. For sleepwalking, there's repeated episodes of simple to complex behaviors. The eyes may open, but they'll be glassy. They're difficult to wake. And it's important to ensure safety with these patients because there are people that will get up, they'll try to drive, they'll try to take pills. That can be very dangerous. So you want to lock doors, windows, make sure that they don't walk anywhere they're not supposed to. For sleep terrors, there's abrupt terror arousal, often starting with a scream. There's marked autonomic arousal, such as tachycardia, sweating. But again, unlike nightmares, where there might be some screams, some sweating, they don't remember it, and that's important. The patient is unresponsive to comfort and settles back to sleep quickly. In addition to NREM sleep disorders, you have to know REM sleep behavior disorder versus nightmare disorders. Now, all these disorders look very similar, which is why test makers like to trip you up on them. So for REM sleep behavior disorder, it occurs in REM sleep, which is the second half of the night. It is characterized by lack of muscle atonia. Features include vocalization or complex motor behavior, such as dream reenactment. Patients are not confused upon awakening. Significance of the REM sleep behavior disorder is it is associated with neurodegenerative disorders such as Parkinson's or Lewy body. So if you have someone with REM sleep behavior disorder, this is something you have to worry about in their future. Treatment is clonazepam. Now for nightmare disorder. Nightmare disorder, there are recurrent frightening dreams occurring during the second half of sleep. Patients have detailed recall of these nightmares, unlike sleep terrors where they have no recall of what happened. Upon awakening, there's also no confusion or disorientation. They are fully alert. Treatment for nightmare disorder is image rehearsal therapy and prazosin. Disorders can be really confusing, which is why I recommend you watch this video several times so that you know them like the back of your hand. Do lots of practice questions because they look so similar. Lots of people get tripped up on them. Good luck on your exam.